Well, welcome everybody. My name is Greg Caruso. I am the director of the Patrick J. Waide Center for Applied Ethics here at Fairfield University. This is part of our annual seminar series, and I'm very excited to have our guest speaker today with us. I'm just going to introduce the center, say a little bit about what we do, and then I'll introduce the speaker. And the presentation usually lasts about 45 minutes, and then it's followed by a period of question and answer that lasts about 45 minutes. You won't be able to see yourself if you wish to ask a question, but when we get to the Q&A, if you use the raise hand function at the bottom of the screen, I'll unmute you and then you'll be able to ask your question. If you prefer, you could also use the chat feature and I can read the question to the speaker. So the Patrick J. Waide Center for Applied Ethics advances learning, research, and dialogue about the leading ethical issues of our time. We have three core missions here at the Waide Center: curriculum, research, and outreach. The center offers about 16 different applied ethics courses, as well as a 15-credit minor in applied ethics. We offer courses in everything from business ethics to environmental ethics to medical ethics, healthcare ethics, ethics in the community, ethics in engineering, and the like. We also support research by students and faculty and members of the center. And we engage a number of outreach efforts. We host an annual lecture at the Quick Center, as well as sponsor an annual seminar series. And next year, we also hope to host two conferences here at the Dolan School of Business. One being the Northeast Alliance for Business Ethics, and then another, hopefully, a 3-day conference on stakeholder capitalism. So those are among the many things we do. This is part of our outreach effort. So this is our seminar series. It's a forum for building community and advancing research and applied ethics. We encourage jargon-free and supportive discussions that will be accessible to participants with serious interest in applied ethics, but who come from a wide range of different disciplinary backgrounds. The invited speakers in the series either present a work in progress or something that's recently published. And about half of each meeting is devoted to question and answer. So I'm very excited today to introduce our speaker, Jennifer Blumenthal-Barbie, who is Cohen Professor of Medical Ethics and the Associate Director for the Center for Medical Ethics and Health Policy at the Baylor College of Medicine. Her research focuses on the philosophical and ethical questions raised by research on human judgment and decision-making, as well as on ethical and philosophical issues in psychiatry, neurology, neuroscience, and AI ethics in healthcare. She's the author of the book, Good Ethics and Bad Choices, The Relevance of Behavioral Economics for Medical Ethics, which is also the title of today's talk. If you like to talk, go out and get the book. It's a very interesting and important conversation. Dr. Blumenthal-Barbie has also served as a member of the American Philosophical Association Committee on Philosophy of Medicine, was co-founder of the American Society for Bioethics and Humanities Medical Decision-Making Affinity Group, and is an alumnus of the Greenwald Faculty Scholars Program in Bioethics. She is currently an associate editor for the American Journal of Bioethics and previously served on the board of directors for the American Society for Bioethics and Humanities. In 2023, she was elected as a Hastings Center Fellow. Very excited, and warm welcome to our speaker, Dr. Blumenthal-Barbie.
So I'm going to be talking a little bit about the ideas in the book that Greg mentioned. And so specifically, I'll be talking about some of these things called biases and heuristics that influence decision-making, and especially patient decision-making, because I work primarily in medical ethics as the area of applied ethics. And then also think a little bit about some ethically justified influence that we might have on patients' decisions, and apply this knowledge to inform consent and decision-making with patients and families. So I like to start out with this quote by Carl Schneider. He wrote a really excellent book called The Practice of Autonomy, which was an ethnographic study of how the philosophical and ethical principle of autonomy actually unfolds in the clinic. There's some real gems in there. And Schneider describes what I think most of us would recognize as the decision-making ideal in medicine and medical ethics. So he says that over the past 40 years, there has developed an assumption that the physician's principal task is just to remove impediments to the exercise of autonomy. And that once those impediments are gone, people will naturally gather evidence about risks and benefits of their medical choice. They'll apply their values to that evidence, and then they will reach a considered decision. So recently, there have been a lot of problems posed for this ideal of decision making, and many of them have come from the field of behavioral economics. I have some of the best-selling books from that field here. I especially recommend Thinking Fast and Slow by Danny Kahneman, who won a Nobel Prize for his work in this area. Of course, the book Nudge became very popular and helped bring a lot of these ideas from the field of behavioral economics into the real world and policy. And basically what this field has shown is that people, and in our context of medical ethics, patients typically use intuition, impulse, and display various so-called cognitive biases and heuristics in their decision making. And what I'm going to do in the first half of this talk is give you a flavor of some of that. So give you a flavor of some of these heuristics and biases and how they play out in patients' medical decision. But first, let me say a little bit about just the idea that decisions that patients make are often very intuitive and impulsive. So this was one of the major findings from Carl Schneider's book and his ethnographic work that I mentioned a couple of slides ago. And Schneider writes that through his work, he found that even patients who were sufficiently well educated and reflective enough to write memoirs frequently described themselves as having no decisional process at all. Instead, they invoked intuition, instinct, and impulse when they were describing how they exercised their autonomy or went about making their medical decisions. Here's a fun study that illustrates this. This was a study done with 130 living kidney donors. And these researchers wanted to study how these people came to make the decision to donate a kidney, which is a rather big decision. And what they found, they did some in-depth interviews and surveys, and they found that 62% described themselves as making an immediate choice to donate, and only 25% of them described themselves as engaging in any sort of deliberation. We've found a really similar sort of thing in our research on decision-making among patients who have advanced heart failure and are making a decision about whether to get a left ventricular assist device that is a sort of heart pump that would take over the functioning of their heart. We've been doing about a decade of research with this patient population, but early in our research, we did about 45 in-depth interviews with these patients to really understand how they were going about this really major medical decision. We interviewed patients who had already made the choice to get the LVAD. We interviewed patients who declined and people who were in the middle of decision-making. And we found that 30 out of the 45 people that we interviewed reported themselves as engaging in really quick and quite frankly, reflexive decision-making. 28 of them even told us that they didn't feel like they had a choice. They found it strange that we wanted to talk with them about their quote decision. And 22 reported deferring very heavily to their clinicians. All right, so now I'm going to shift. So that's just giving a little bit of a sense of how patients' decisions are often very quick and intuitive. Now let me get a little bit into this heuristics and biases stuff. So one of the most studied biases in behavioral economics is something called the loss aversion bias. And this is an effect where losses loom larger than gains of equal magnitude to people. So let me give you an example to make a little bit clearer. This was a study done looking at people's decision around a hypothetical angioplasty. So this is a heart procedure. And what these researchers did is they varied the way that they presented this choice. So to one group of people, they told them, look, This procedure has a 1 in 100 chance of complications. So this was a loss framing. For the other group of people, they got a gain frame. So they were told that 99 in 100 people have no complications. So we have the benefit now of seeing both of these things side by side, and we know that they mean the exact same thing. But you can see here that the people who received the loss frame information, 49% of them said that they would refuse the angioplasty. They would not consent to it, compared to only 15% who received the gain frame. And that's because that loss frame is very, very influential and powerful influence on people's choice. Another example of loss aversion bias, this study was done not in a hypothetical decision, but in the real world. So what these researchers did is they mailed pamphlets to a bunch of women who were due for their mammography screening. But for one group of people, they really emphasized loss framing, so the risks of neglecting mammography. And for the other group of people, they received gain frame messages talking about, the benefits of getting your mammography screening. They then followed these women for a year, and they found that more people who received the loss frame information had actually gone and gotten their mammography, because again, that is more salient and more of an influence in people's choice. Here's another bias called the frequency bias. And the idea here is that information, like risk information that is framed in terms of frequencies, is more influential psychologically to people than those that are framed as percentages. And that's because the thinking behind this is that percentages seem rather abstract to people, whereas when you tell them frequencies, they can sort of concretely imagine, like 2 out of 10 people and them being one of those 2 people or something like that. This is a fun study done to demonstrate this bias, and I like to give this study because this is actually a study of clinician decision-making and not patient decision-making, just to show that these biases are present in all of us, and even in clinicians, even though the bulk of this presentation is trying to think really carefully about what it means for patient decision-making and patient autonomous choice. But this was a study done with psychiatrists. And so what they did is they told psychiatrists, they gave them a hypothetical vignette about this patient, and they were asked if they would discharge this patient. And for one group of psychiatrists, they got the hypothetical vignette describing the patient, and then they were told the patient's risk of violence was 20 in 100. The other group of psychiatrists, same vignette, and they were told it's 20%. And you can see here the difference, that the people who received the frequency information, more of them, 41% of the psychiatrists, said they would refuse to discharge that patient, compared to the group that received the more abstract percentage, because that just felt less salient to people than the frequency. Here's another fun effect. This isn't really a bias, but I like to put it in just because it shows the power of psychology. So this was a study, I believe this was published in JAMA back in 2008, but this was looking at the effects of even telling patients that they are receiving a discount drug or a generic drug. Just that labeling of the drug has a powerful impact, not on their choice, but on their perception of how effective that drug is. So this was a placebo drug. Both groups were given the placebo. It was a drug for pain reduction, but one group were told that it was the regular price drug, and the other group was told it was a discounted or a generic drug. And then they asked patients how effective they thought the drug was. And you can see here that the people who received what they thought was the cheaper or generic drug, they reported it being less effective at pain reduction, and they even reported a little bit of a pain increase. Relative risk bias. So the way that there are a couple different ways you can cash out this bias, but the way that I'm cashing it out here is just the effect that when you give people their risk information in relative terms, meaning in comparative terms, sort of where they fall compared to an average or another person, that can be extremely influential compared to just if you give them their risk information by itself, like their absolute risk information. So for example, this study was done with about 300 women who were at risk for developing breast cancer. And one group of women, they were just told their risk. It's something called a Gale score clinically. So they were given their risk information. The other group of women, they were given their risk information, but they were given it relative to or comparative to the average woman and how at risk she is. And this was a group of women who were at higher risk. So suddenly they're seeing their risk score, but they're seeing it comparatively compared to the average risk. And they're knowing now that their risk is higher. So just that sort of relative or comparative framing of risk really changed people's perceptions and their behaviors. So these women who received the comparative information, they reported themselves as being more worried about developing breast cancer, and they actually engaged in more screening. Something called comparison contrast bias, also sometimes called a decoy effect. The way I like to think about this is that we all have a tendency for what feels like the middle of the road option, right? So you go to like a gas station to get a drink or Starbucks or whatever, and there's very few people that are going to get like the big gulp, and there's very few people that are going to get the tiny little cup. Most people are going to be somewhere in the middle. And that's a psychological effect or a bias that we all have. So when people are making choices, the result is if you give people two choices like A and B, they might not have a strong preference between A and B. And then you suddenly introduce a third option, C, and now you'll see them gravitate towards choice B because it feels like the middle of the road choice. So this has a powerful effect. Choices can be shaped by this effect, intentionally or unintentionally. This is what happens, by the way, when you are getting cable and you're working with a cable company. They know that you're going to gravitate towards the middle of the road option. So they'll actually probably take a package that is more than you need and present it as the middle option. So I would just say, this is like practical advice, but take a look at the lowest price option and see if it might actually meet your needs so you don't fall prey to this effect. Recency and primacy biases. So this is a kind of another order effect thing, but essentially whatever people hear about first and last is most influential in their decision making. So a study here, it was done again with women who were at risk for breast cancer, and they were being told about a preventative drug, tamoxifen, and being informed about this, and then were thinking about whether they might want to take this drug. And these researchers, they just played around with the order in which these women heard about the risks and the benefits. So some of them heard about the benefits first, then the risks, and then the benefits again. And then others made sure that they heard about the risks first and last. And what they found is that the women who heard about the benefits first and last, they were actually more interested in potentially taking this drug. Again, because of these recency and primacy biases and the powerful effects of like what is most recent in our memory. Omission bias. This bias got a lot of attention during the pandemic because it's been studied a lot in vaccination decision making. So this bias refers to this tendency that we have to think that bad outcomes as a result of non-action are somehow better than ones that are, quote, caused directly, even if the ones that we allow to happen are actually worse or cause more harm. So one of the older studies looking at this bias in vaccination decision making, it just gave people like a number. Okay, imagine a risk of death that's like 1 in 100,000 or some, really, really low risk. And they asked people, how tolerant would you be of that number, of that chance of death? But they just varied the cause. So some people were told that number was going to come from the illness itself. Other people were told that that number was going to come from the vaccination. And you see here that the people, if it came from the vaccination, they were less tolerant of that number than if it came from the illness itself. And objectively, rationally, like you should be stable in terms of how tolerant you are of that risk of death, regardless of the source. Interestingly, there's also something called a commission bias, which I think is really relevant for medicine and medical decision making. And we've seen this studied a lot in cancer care. And this is a bias that we have to just want to try something. And the idea that trying something or action is better than trying nothing. And this is a really fun study that illustrates this bias in medical decision making. This was a study where people were given a hypothetical cancer diagnosis. They said, imagine you have like prostate cancer and you have these two choices. You can either get treatment or you can just like watch it. We can wait and we can watch it and we just make sure it's not growing. And they were told, treatment carries a 10% chance of death and watchful waiting carries a 5% chance of death. And what they found is that despite the higher chance of death, 65% of people said that they would want to do treatment. And they attributed this to this like commission bias of this urge that we have to just like do something. All right, I got a few more biases, and then I'm going to shift to what I think are some of the ethical implications of all this really fascinating behavioral economics stuff. Availability bias. So this bias refers to the idea that whatever is sort of most recent, vivid, or memorable is also going to seem most likely, and then is going to be most influential in people's decisions. So the study I like to use to demonstrate this bias was a study that was done, published in BMJ back in 2009. And what this researcher did was they gave people a sort of description of what life would be like with advanced dementia. So they said, look, if you have advanced dementia, that means you're not going to be able to eat, communicate, ambulate. The other group of people, they were also given that description of what advanced dementia was, but they saw a 2-minute video of a real patient with advanced dementia. And then they asked both groups of people to like indicate their preferences around whether they would want comfort care only or different forms of more intensive treatments if they were in that state. And they saw that they found that the people who saw the video, more of them said that they would want comfort care only, that they would not want more interventions in such a state, because that made such an impression on them, that 2-minute video, and it was kind of so salient in their decision making and really drove their preferences. Default bias is definitely one of the most well-studied biases in behavioral economics and an incredibly powerful bias. It refers to the fact that we kind of like to go with the status quo and we don't like to make active choices, or we don't like to override the choices that have been made for us. So you can get a lot of mileage with people just going with the flow and kind of going along with whatever like choice or action you set up for them. At a policy level, this is probably most talked about with respect to organ donation. Some countries have policies around organ donation that are opt-out. So the default is going to be that we presume you give consent to having your organs donated unless you've opted out. Obviously, here in the United States, we have a different default. We default to presume not consent, and you've got to opt in and consent. And you see really, really vastly different rates. We're talking like in the 90% donation rates in European countries to, I think last time I checked, maybe around 50% in the US or something like that. But this also can be a bias that influences people's individual medical decisions. So for example, this was a study looking at kind of playing around with defaults on advanced directives, and found that if you set not life-sustaining treatment as the default on an advanced directive, then that had an influence, that less people would override that and actually want treatment, compared to if you set life-sustaining treatment as the default, then 38% of people kind of went with that default. So more people were saying that they would favor treatment. In this particular study, they actually did a debriefing. So they went back to people and they debriefed, and they said, you were part of the study. We were setting a default on your advanced directive. Do you want to change it? Like, would you want to go in and make a change? And the default bias was so powerful that I think nobody even wanted to go back and make a change, right? They were like, it was like a meta default. All right, I think I've got maybe 2 more biases. Impact bias. So I think this one is really important for medical decision making because it involves the finding that we do a pretty poor job at anticipating our future mental states, our future well-being, and our future quality of life. So this has been studied a lot in the context of disability and the disability paradox. But here's a study about how it played out in dialysis decision-making, or how it could play out in dialysis decision-making. So these researchers, they went to patients not on dialysis, to healthy controls, and they said, imagine that you had to live life on dialysis. What do you think your life would be like? And they had like a little mood score that they were having them tap into with a little kind of beeper on their waist every couple hours, and indicate, like, where do you think your mood would be if you were on dialysis right now? And people thought it would be really negative. They thought, oh, if I had to be on dialysis, it'd be really negative. I'd probably be like a minus 0.2 in this mood score. Then they went to people who were actually on dialysis and asked them to do the same thing. And you can see the results here. They were quite positive. It was like a 0.63, and it was actually close to where patients who were not on dialysis were in reporting like their kind of daily mood. So we have this enormous ability to kind of adapt to negative states, but we don't really appreciate that about ourselves. And I think that that's really significant in an area like medical ethics and medical decision making, because often we're asking people all the time to try to imagine some future health state and then make a decision based on it. This is just a study to show that this bias also goes in the other direction, which is sort of overly optimistic. Like, people also think that there's going to be some hugely positive impact from something like an organ transplant, and it's, they're going to be able to have so much energy and work so much more. But that actually doesn't match up with what the reports were post-transplant. All right, the final bias I'm going to talk about is something sometimes called escalation bias, cascade effects, or sunk cost bias. And the idea here is that we have this tendency to just keep going down a path because we've already been going down it, because we've already like sunk some kind of cost in, we've already sunk money in, we've already sunk time in, so we're just going to keep going. The original behavioral economics studies around this effect, a lot of them were done with movie tickets and looking at how, you buy a ticket to a movie, you go to the movie, it's really awful. Like, the rational thing to do is just leave. You can't get your money back. You've already bought the ticket, but you can get your time back. So you should at least leave. But people don't leave. They sit there, right? And they like stick it out through the movie. And there's like kind of social norm stuff that goes on, but there's also just this idea of like, well, I already paid my $12, so I'm gonna get my money's worth. It's like, you're not getting your money's worth. So this plays out in medical decision making as well. A study that was done was looking at why patients would continue a physical therapy plan when it clearly wasn't working for them. So these were patients where they had just been physical therapy after physical therapy, not making progress. And so these researchers wanted to kind of study why. This was a little puzzling. And they basically found a sunk cost effect, that people said, well, I've already put so much money into it, so I've just got to keep going and keep trying more. So there are a lot of these heuristics and biases in medical decision making. Years ago, I did a kind of systematic review with a research assistant. We found over 200 studies, and that was about a decade ago, so I'm sure there are more. There were 19 different types of cognitive biases that were studied in patient and clinician decision-making, and most of the studies that were looking at the presence of a bias confirmed its presence. So they're there, they're operating, and they have a lot of effects. So what does that mean for ethics? So for me, there are kind of two major areas of implication. And the first is thinking about its impact for how we think about informed consent and autonomy. So if we think about even something basic like the elements of a patient patient who is informed making a capacitated decision, that they have to have understanding, they have to have reasoning, they have to kind of appreciate the numbers that they're given about the risks and benefits and how they apply to them. And then they've got to make a clear and consistent choice. Then you think also about, what do we mean when we talk about autonomy? Well, we talk about, people being able to govern themselves, act according to their own preferences. In the bioethics literature, these are kind of standard criteria for autonomous choice and action, is that they're intentional, they're based on understanding, and there's a independence of controlling influence. So I think, given all these findings from behavioral economics about errors in forecasting future preferences, the fact that preferences seem to be so often dependent on context and framing effects, all these different biases, the fact that many decisions are actually gut decisions. For me, the ethical implication number one is that I think patients' decisions are not as often autonomous as we typically have thought or assumed that they are. So that's conclusion number one. Conclusion or implication number two is sort of setting aside, how we think about autonomy. Should we be concerned that some of these biases and heuristics can actually lead to harm to patients, can lead to them making decisions that harm them in some way or like set back their interests? And I think that the answer is yes. So I've got lots of examples in the book, but here are three. These are all real examples. So imagine you have a parent who does not consent to a beneficial surgery for their child. Why? Well, because they know somebody who had that same surgery or a similar surgery and died. Like now we have a label for that. We can say that's the availability bias at play. Imagine that you have a parent who refuses a treatment for their child because they mispredict the impact or the burden of that treatment. They think it's going to be worse than it actually is. That's an impact bias. And I realize now, actually, these are all like parent examples because I think these are left over for when I gave a version of this talk to a pediatrics audience. But you can imagine these are just replace parent with a patient, right? Third example, imagine like, a patient who has like a low risk medical condition, but they request some kind of immediate treatment that has some really bad side effects. And that's a commission bias at play. So these are all case examples where we now, from tools like from the field of behavioral economics and decision psychology, we can start to put labels on these effects, and we can start to see how they can lead to actual like choices that are harmful to patients and their interests. So what should we do? Hopefully I've convinced you that these effects are worthy for us to pay attention to and care about. They're ethically concerning. So what do we do about them? So I'm going to put, here are kind of three possibilities. Possibility number one is a sort of return to old school paternalism. We just say, oh, well, people's decisions are not as autonomous as we typically think. So that means that we can just override them and we can just do whatever we want to do, whatever we think is best. That's an extreme in one direction. I think that is unwarranted. Here's an extreme in another direction, which is maybe the more positive direction. You might think, oh, well, we just need to kind of debias people. We need to get rid of all of these biases and heuristics, and we just need to return them to a sort of like rational, autonomous decision maker. I think that this is not going to work. This is not possible. There are lots of reasons. Briefly, I'll say that there has been a lot of research on debiasing and the possibility of debiasing. And there's been some success in debiasing people around sort of like statistical errors, like gambler's fallacy, and teaching people to like reason about statistics a little bit better. But most of the debiasing attempts around what I would call the deeper psychological biases, like the fact that like whatever we hear recent is really vivid to us, whatever seems like most vivid is what we think is going to be most likely, default effects. These are all very, very resilient and hard to get rid of. And I also think that what I hope you're beginning to appreciate is that they're inescapable in another way, which is that we have to frame choices to patients and we have to present choices to patients in a way. And the way that we decide to do that will inevitably have effects and influencing their choice in one direction or the other. So I think that where I think is the most ethically justifiable conclusion of all this is that what we should really be doing is we should be actually harnessing the power of these biases and heuristics and rechanneling them to lead patients towards decisions that are more accord with what their interests and their goals actually are. And this is the idea out there of like nudging or, shaping choices. So the way I think of one way of thinking of nudging is just harnessing our knowledge from these fields like decision psychology and behavioral economics to lead patients towards decisions that are more accord with their values and goals. This is sometimes called choice architecture. In their book Nudge, Thaler and Sunstein talk a lot about choice architecture and choice architects. And what they say is that a choice architect is someone who has the responsibility for organizing the context in which people make choices. And that many real people turn out to be choice architects, most without even realizing it. Then they actually name a bunch of people, but one group that they name are physicians, that physicians are inevitable choice architects. There are a lot of tools of nudging, and I'll just draw your attention to this great report. This was a report, the Mindspace report came out of the UK, probably a little over a decade ago now. But this was a group of like behavioral scientists who were tasked with thinking about how behavioral economics, the science of behavioral economics and decision psychology and nudges could actually improve policy. So we could bring some of these insights to policy and to policy making to have it have its greatest impact. So this is a really great report. I think it's long. There's a short version and a long version. The long version is about 100 pages. The short version is something like 15. But there's a lot of really good stuff in there. And it's really just about this insight that the cognitive heuristics and biases that I've been talking about can really be leveraged to shape decision making in positive ways, and that those then become kind of tools of or prime examples of nudging. And there's also, I'll draw your attention to, there's a philosopher, Yashar Sagai, who has done a lot of really good work on nudging and just trying to think about the definition of nudging. And so for those in the audience who are more philosophically inclined, I really like Yashar's definition of a nudge. So he says that A nudges B when A makes it more likely that B will phi, like B will do some kind of thing, make some kind of decision, primarily triggered by B's shallow cognitive processes. So those are all the things I was just talking about, like the heuristics and biases. These are all shallow cognitive processes. While A's influence preserves B's choice set and is substantially non-controlling. So we're not talking about taking choices away, taking choices off the table. We're not talking about threats. Those are all sort of in different areas of inquiry. So I'm going to end with a few thoughts about ethical nudging, or how we can do nudging in the medical setting in an ethically defensible way. So the first thing I'll say is that I think that this power, and I really do think it's a power, and that these are really powerful effects, should be used reflectively. So I would say one of the things that I've most admired over the years is giving a version of this talk to a group of palliative care physicians up in New York, who really took it upon themselves to study these biases, study the literature, and integrate kind of discussion of them into their discussion about cases. So they would ask, is this patient, we have this patient, they're refusing X or Y. Are they refusing this because of a sunk cost bias? And what would that mean? And are we falling prey to some kind of bias? Are we as a team falling prey to like an availability bias, because we just saw a case that was similar? So I think like just developing an awareness and language around these heuristics and biases and being really reflective about them, I think is ethically crucial. The other thing is that I think we should make sure that to the extent that we use any of these insights or nudges, that we should really make sure that we're making our patients' interests central in the context of medicine, and not our own. So it's interesting when I've talked about these things with some physician groups, there's always somebody in the audience who is worried about a bad actor physician. They're like, well, are you just giving physicians all these tools to, manipulate their patients' choices and have them make choices that, make them choose a surgery that the doctor is going to make more money from or something like that? And I like to think that my colleagues in medicine have more kind of professional integrity and take their professional and fiduciary obligations to patients very seriously. But of course, I think it's important for us to keep in mind that these are things that we should use, keeping our patients' interests central. I also think we can draw a distinction between cases where it's really clear that a particular treatment decision or health behavior would foster a patient's values and goals, and cases where it's not. So there are cases where we just don't know, like maybe there's a lack of medical evidence. We don't really know what treatment choice would be best in line with their interests and goals, or we don't know anything about this patient. We don't know what their interests and goals are. So those are cases where we'd want to sort of pull back from nudging. I think it's something that I don't think we can avoid totally, because as I said, I think there's no such thing as a neutral choice, but I think we can certainly do more or less of it. And those would be cases where it would be appropriate to do less of it. I also think the cases where we might be most tempted to use some of these insights to kind of shaping choice are going to be cases where we don't like somebody's choice. Like we don't like a decision that they're making. We don't think that it's good for them. And so we want to maybe try to change their choice. And I would just say that it's important for us, I would say, to think about where their choice is coming from and draw a distinction between like a choice that maybe is influenced by somebody's biases and heuristics, and one that is really influenced by maybe their legitimate goals and values, even if we disagree with them. So the example I like to give is a patient who maybe is refusing a blood transfusion because they're a Jehovah's Witness. That would be a case where it's inappropriate to try to use insights from behavioral economics or nudges to influence their choice in another direction, because they are already making a choice that is actually in line with their goals and their values, even if you don't agree with them. And then the last thing I'll say is, I think in the medical setting, it's really important for us to, if we use some of these tools or we engage in nudging, to do it in a way that doesn't kind of alienate patients or their family members or harm their relationship. In the context of medicine, the relationship that physicians have with their patients is really, really important. And if patients perceive that any of these techniques are being used in a problematically manipulative way or as a scare tactic, then that has the potential to really harm the relationship, which I think would be an ethical concern. So it's a little bit of an art, I guess, about kind of how to use these insights in a way that does not really alienate patients. But I think that's something important to keep in mind. And anecdotally, I really thought about this point because I was once working with a pediatrician who said that they had stumbled upon some of the research from behavioral economics and got really excited about it because they thought that they could use it to nudge families to vaccinate their kids. So they developed all these videos really trying to draw on like saliency and loss aversion, and videos of kids who had lost their lives or had really significant bad effects from not being vaccinated. And what they found when they took those into the real world is that it kind of backfired, that a lot of the families who were hesitant said, oh, I feel like you're really trying to scare me or you're trying to manipulate me. And so that had actually a negative effect on the relationship and also on their decision making, because at the end of the day, then they did not decide to vaccinate. So I think those are my ethical considerations or guidelines, but it's not always easy. And I would say it's quite hard. What I like about the area of thinking about the ethics of nudging is how any area that you apply it to, you really get in the weeds and it gets tricky to try to apply some of these ethical principles. So I'll just float 3 areas that I've been doing some work in recently, where even though I've worked on nudging for a long time and the ethics of nudging and written a book, it's still really hard to figure out whether it's right or wrong to use certain nudges. So one was a study that I did with some pediatric intensive care docs, and we were trying to understand how they approached informed consent and decision-making for this. Because these were children who had very kind of devastating neurological injuries, and they had to make a decision about whether they want to proceed with the tracheostomy. And some of them talked about, quite frankly, like intentionally or unintentionally using nudges. So they said, you know, what I do is I just really try to make the harms and the negative aspects of a trach salient. So I'll talk to them about, you know, I'll use terms like, you need to think about what it's going to feel like to have a hospital in your living room. Now, that kind of phrasing and that kind of imagery is probably going to be a pretty powerful nudge or have a pretty powerful influence on their choice. Is it ethically appropriate? Another area we've done some work in is looking at consent and decision making for deep brain stimulation in pediatrics. So these are kids who have a really intractable movement disorder called dystonia, where they're really not able to move their limbs at all. It's often quite painful. There's a treatment, deep brain stimulation, that could potentially give them a lot of relief, but it's, you know, uncertain. There's still a decent amount of uncertainty around it. So we talked to some of the doctors, and they said, you know, what I do when I approach people about this decision and try to get consent is that I worry that they are coming in unrealistically optimistic about this decision. So I intentionally try to emphasize how uncertain we are. I intentionally try to emphasize like the potential risks, because I'm trying to like counter what I take to be some potential unrealistic optimism. We also talked with the parents, by the way, and they realized this. They said, you know, the surgeons come in and they talk to us about this, and they're just so negative. Like a lot of them are so negative. They're really kind of like laying crepe about you know, the negative possibilities. And so they felt like they were kind of steering them in the negative direction. What is the right direction? And then the final context is decision making, as I mentioned at the beginning, around LVAD therapy, which is an area we've been working in for probably the past decade now, developing a lot of decision support tools and trying to improve and understand patient decision making. And we in our team have had a lot of very active discussions and debates about some choice architecture decisions that we have made. So, for example, we include stories of other patients who have gotten this device. We had a lot of debates about, do we include negative stories and positive stories, an even mix? Do we make sure that it's representative? Like most people, actually 80% of people have really a positive experience. So should 80% of our stories be positive and 20% be negative? Because again, we know from behavioral economics that like those stories will have a very, very powerful influence on people's decision about LVAD therapy. We also recently have been able to give patients personalized survival estimates. So we take their clinical data and put it into a calculator developed by our colleagues to give them their personalized estimates about 1 and 2 year survival with or without the LVAD. So we had some really active debates about whether to frame that in terms of survival or mortality, because again, we know that that frame is going to potentially have a really powerful effect. So this is just to say that I think what has been really challenging but also fun about this area is that I think that applying it in every little kind of particular context or in the weeds, so to speak, just generates a lot of different areas of discussion and debate. So it's been really fun. As Greg said, if learning about these heuristics and biases has been interesting to you and thinking about some of the ethical implications and issues, you can read a lot more about that in the book that I finally put out there in the world a couple of years ago. And that's all I have by way of didactic. And I know we're going to open things up for questions and discussion now. So I'll hand things back over to Greg.
Well, thank you very much. That was really, really wonderful. For audience members, there's a navigation bar at the bottom of the screen. If you have a question, you could click on the raise hand button and I'll unmute you. And you can ask your question. If you prefer, you could also type something into the chat and I could read that. If anyone has a question, I'll wait a second to see if anyone raises their hand. Oh, okay, someone raised their hand. All right. So I think it's Kei Kwan Sun. I'll unmute you. Hold on. Okay. You should be able to speak now.
Hi, thank you so much. This was a very interesting talk. My name is Kei Sun. I'm a behavior economist in the Department of Economics here at the Dolan Business School. I view nudging in a sense, I'll try to represent the economist as much as possible. But in my view, what we see nudging is essentially that we suggest people to, well, you gave a very good definition of what nudging is. We influence their choices. We want them to choose an option A over option B. Presumably, the policymaker thinks that option A is clearly better for this person. That's why, without dictating their actions, we increase the likelihood that this person is choosing option A, which, I'm not going to debate whether that policymaker's preference is necessarily in line with this individual's preference. But my question is, so essentially the mechanism that we think is that the way the nudging works is we shift the cognitive cost from one option to another by making one option to be more salient, more easier to choose. Well, we could do the same with, say, with financial incentives. We could make this less desirable option from the policymaker's perspective. We could add, say, monetary cost to it, but that would typically be understood as an unethical behavior from the policymaking side. So from your perspective, how does nudging differentiate from using financial incentives to deter people from choosing a less desirable action from policymakers' perspective?
Yeah, that's a great question. And thanks for attending the talk. It's really cool to have a real behavioral economist here. So a couple of things. One is that, first of all, I'll say I think that ethics has had a problematic relationship with their view on financial incentives. Meaning that I think a lot of ethicists have argued that financial incentives are all often problematic because they quote unquote coerce somebody to do something that they don't want to do, maybe. I'm thinking in the context of, for example, payment for participation in research. There's been a lot of research ethicists who have said and IRB members who, if you want to offer any amount of payment, they'll start to raise concerns about coercion and have ethical issues with it. I'm really convinced by the literature that has pushed on that quite a bit, questioning whether those incentives would really be coercive and, arguing that that's not typically what we mean by coercion, to offer somebody some sort of positive incentive for things. And maybe at best, we might want to be concerned with what they call undue influence, meaning that maybe the financial incentive might cause somebody to be so fixated on it, like the sunny coin, that they then ignore some of the risks. And so they don't actually make an informed choice because the financial incentive is just like so distracting. I mean, there's empirical work to be done about whether that is the case. But anyway, that's the first thing I'll say, that I think that the view that financial incentives are unethical is one that I think I would challenge perhaps more than many ethicists would. The second thing is that I think for some settings, like in the context of medicine, it's just not practical to pay people to make a certain choice, like where are we going to get the money from? So I'm really thinking about the context of medicine and people's medical choices, where in many of those situations, it's just a practicality that's not one of the things that will be available to the person in their toolbox to, influence choice in a particular direction, such as the individual doctor that's presenting the choices to the patient. And then the third thing is that I think you make a lot of really nice distinctions, or just a point about the different types of costs. So, you know, there could be a shift in financial costs from option A to option B. There could be a shift in like physical, like what somebody has to physically do to choose A versus B, emotional costs, psychological costs, costs around like stigma or shame. These all become potential tools of the nudger. And this is where I do think like some of the weed stuff gets interesting, right? If you use like shame as a cost, especially in particular context or with particular populations that have been vulnerable or have been stigmatized in the past, that might be ethically unacceptable, right? Whereas maybe financial incentives wouldn't. So I really like your point about thinking about like the different types of costs that could be shifted from options and the ethical implications of that.
Did you have any follow-up question?
Yeah, I really appreciate your answer. And to be honest, that makes me feel much better because I've been explaining that my experiments aren't harmless to many IRB
Yeah,
questions that, hey, I pay people, but it's not to coerce them. So I
right.
really appreciate your perspective on that.
And
I really,
there's literature too, just so, I mean, if you want to connect offline, or I would say there's like a lot of literature, like empirical literature and ethics literature to kind of make that point to them, because we've had to make a similar point in some contexts.
Thanks. Yeah, I'll email you for that. As a follow-up question, I really like how you brought up the shame as a different
Yeah.
cost. So for instance, you mentioned that this physical fiscally it's difficult to provide financial incentives to patients, but it could also
Mm,
work in the opposite direction, say uh, make less desirable choices, say option A and option B. The hospital believes that A is better choice than B. Um, so nudging is to increase the likelihood that the person will choose this treatment A despite the potential cognitive biases behind their decision-making processes that could potentially hinder them choosing what's best for you. But again, this is coming from the practitioner's perspective. So if that was the case, I'm hypothetically speaking, if there's a way for the hospital to connect it to health insurance claims, such
mm,
as that if you go against their recommended
mm,
advice, the insurance claim will become much more expensive. So
mm,
you don't have to pay them, but you can it
mm,
make the cost inhibitive in a sense that functionally it will do the same job as this nudging,
mhm,
depending on the magnitude of this, but that
mhm,
will still be considered less ethical. At
mhm.
least that's how I will feel if I were in
Mhm.
that situation. But from your perspective, how would you distinguish these two different approaches?
Yeah, I mean, well, I think this is interesting because I know that a lot of like insurance providers actually are connecting incentives and disincentives to certain health behaviors and health outcomes. So my insurance company does this, for example. And I think this is where framing is interesting, because it's not often framed as a disincentive, right? That if you don't maintain a certain blood pressure or do a certain number of things, like you're going to get fined. But it essentially is that. It's more framed in terms of, you know, here's how much you're going to pay for your insurance. But if you do these things, you can like get a positive incentive of a discount or something like that. So even the people who set up the policies are understanding, right? Like that
Right.
essentially you're getting, you know, essentially you're getting fined if you don't do certain health behaviors or maintain certain health outcomes, but it's framed or presented as like, you know, a bonus that you might get, which I think is really, really interesting. And the other thing I'll say is, you know, I think your point raises a consideration that I didn't talk about, which is just, you know, there are health decisions and health behaviors. And when we start talking about health behaviors and the use of nudges for health behaviors and like rewarding certain groups, and it's, for some people, it's harder than others, right? They have more barriers, like internal barriers, systemic societal barriers to achieving certain health outcomes or certain health behaviors. And so I think that's an area too where there's been a lot of debate about the ethics of nudges and kind of disparities and unfairness in kind of how easy or hard it is for different groups to, achieve the carrot if the nudge is a carrot, or be susceptible to the stick if the nudge is a little bit more in stick territory.
Thank you. Anyone else have oh, I see Eric. Eric Peterson.
Perfect. Thank you so much for your talk. I really appreciate it. I'm interested in the impact bias and the forecasting errors, because some of my work is on imagination, and I've seen elsewhere, right? There's a ton of work that shows that we're just pretty bad at imagining our futures. And I was curious if, so other recent work, philosopher Amy Kind is doing work on arguing that imagination is like a skill, so that it's something that we can get better at. And I'm curious if you have found anything like that, any studies where through practicing sort of imagining maybe themselves in the future, or anticipating, like, would there be data, or could they get actually less errors in terms of how, like they're overvaluing something?
Well, I'll say that I don't know this literature specifically on the impact of imagination for overcoming the impact bias. You probably know more about it than me. I think that you're right that it's a promising area to think about. I guess I would say I'm initially skeptical about its potential. For a couple of reasons. One is just because, I mean, in order to get somebody in the imaginative space, you have to give them material, right? Like you have to give them the story of a patient, in that state, and tell them to imagine what it would be like if that was them, if they were in that state. But then you're back to those problems of like, well, which story do you give the patient to imagine themselves being in? Like, do you have them imagine themselves like the patient who had the bad outcome and the patient who had the good outcome and the one who was in the middle? Like, what are we asking them, I guess, to imagine is also, I think, going to be fraught with these kind of like choice architecture decisions. But I don't know what you think about that.
Yeah, no, I think I agree with that anytime you try to present a narrative, or there's going to be a framing issue. Yeah, I think I'm on board with that. I guess I was wondering, so it might not be like in the actual, clinic, or when you're providing the decision, but I wonder still if there could be sort of more like diachronic, I guess, like over time, we're gonna first do like that study initial that showed the the errors in anticipating, and then like present them over a course of, I don't know, weeks or something like that, where they're actually imagining different scenarios, and if it would just be different results, like if I don't know, I'm kind of interested in that.
I think it's super interesting. And I think it's like on the one, so I also do a lot of work on ambivalence and like the philosophy of ambivalence. And I think there's one way in like it's interesting because one of the proposals for overcoming ambivalence by the philosopher Emile Rorty is imagination, right? Like if you're really truly ambivalent about something and a decision, like imagination is a way to overcome the ambivalence, right? To really spend time and space thinking about, your like self A versus self B, and really engage in those kind of imagined activities to overcome it. But I mean, it is ultimately an empirical question. And I guess now when I think about it a little bit, I worry that imagination might make the ambivalence worse, because you're, as you said, you're imagining like this, like if this happens versus if that, like if I choose this versus I choose that. And to me, it's just like, it would probably make it worse for me, the decision harder, and like the ambivalence worse. But I don't know. It is an empirical question.
Yeah,
Wait, some more questions. Thanks. So I see a question from Marco, and then there's a question in the chat. So I'll go to Marco first, and then I'll read the other question. So Marco?
Thank you so much. Good morning from New Zealand. Thanks for your talk. It was awesome.
Oh, thank you for coming from New Zealand.
Yeah, thanks.
You talked about three solutions options. So from what I understood, override, debias, and harness. And then you seem to reject option one, which was override, quite categorically. And I was wondering, couldn't we argue that different options are more or less justifiable in different scenarios, especially on the degree and extent of the risk to patients, or in your case, patients? So, for example, assume you have a biased decision maker who risks devastating consequences, and perhaps for a larger number of people too. For example, imagine you have a parent of 6 children who need treatment. In a case like that, overriding autonomy, which admittedly represent harm of a kind also, does seem like the lesser evil and therefore much easier to justify. So I was wondering whether you're open to case-based weighing of that kind, and therefore to the use of different options, override, debias, or harness, in different scenarios.
It's a really good point, and I think that the answer is yes. So for example, like some of the work that I've done is thinking about like influencing the choices of patients in psychiatric settings. And I mean like psychiatric settings where patients their capacity is impaired in some way, you know, they're in the hospital involuntarily. And so the psychiatrist and I that have done this collaborative work together, like we actually talk about, you know, the sort of like taking away choice or overriding choice, or you know, overriding autonomy is kind of the last resort option, but it can be justified in exactly what you're saying in the cases where the person's autonomy is impaired at the moment, like they're not making an autonomous choice, and they're going to like suffer really grave, harmful, irreversible consequences from their decision. And the other case that we talk about is also where overriding their autonomy in the moment might be necessary to preserve it longer term. So I think that you're right, that it's like that slide probably needs to be modified, because I do think that there are probably cases where overriding choice, or kind of like a more stronger paternalism is justified.
Yeah, I suppose you do run the risk anyway that if once you start defining autonomy in a rather specific and, you know, of course, a philosophically informed way, that, well, you're not really overriding autonomy, because you're arguing, well, there isn't really autonomy, there isn't much to override to begin with. So I guess you run into a kind of a different line of problems that way.
I think that's right. I mean, in the book, I tried to marshal like a lot of different defenses of nudges, but one of the defenses is to kind of characterize them as a sort of soft paternalism, right? That it's really like somebody's about to do something that's not really autonomous.
Yeah.
And all you're doing is actually stopping them from doing that non-autonomous thing. So it's merely soft paternalism, which is definitely a justified kind of paternalism on most accounts. And I mean, maybe even like obligatory, right? To stop somebody. I mean, in Mill's famous example, to stop somebody from crossing a bridge that they don't even know is broken, right? You're stopping somebody from doing something that is not like a fully informed autonomous choice, that can be an ethically good or even obligatory thing.
Yeah. Thanks so much.
Yeah, thanks.
Well, in fact, Thaler and Susstein call it libertarian paternalism, right?
Mm-hmm.
Yeah,
that's right. They think I mean, for them, I mean, their definition of paternalism, like the reason why it's paternalistic is because you know, you're intervening and shaping choice, but they really still want to restrict to paternalism in the sense that we're just trying to get you to your own choices, right? Like it is really a soft paternalism is what they mean for it to be.
Yeah, I'll read Jason's question, and maybe if I have time, I'll ask one myself. But so Jason asks, curious if your research in ethical nudging includes or accounts for practitioners' cultural competencies. So ethical cross-cultural nudging.
No, I think it's a really important area to explore more. To my knowledge, there has not been a lot of research done thinking about the intersection of like cultures and cultural beliefs and preferences and the intersection around like nudges and biases. So I have not done that research myself. I don't think that a lot of it has been done, at least that I'm aware of, and I think it would be a really important area to do some work in.
Let's see if there's any other people. I'll just jump in then if we
Yeah.
have a little time.
Yeah.
So for any of my students that are still on, we will be talking about nudging and business ethics soon,
Mm, mm,
right after the midterm. And I was
Mm.
drawing a lot of connections between the context and medical ethics and what I am going to discuss. One thing, I'll go back to Marco's kind of not necessarily, but this three-part set of solutions, what to do, right? So override, debias, a harness. I agree with the debias, at least the stuff I've looked at. Not very effective in the long term, and also not very effective in terms of multiple biases.
Yeah.
Yeah. So an override has some issues, of course. Harnessing makes sense to me in the context of medical ethics, and it makes sense in the context of public policy. And in my own sort of views on nudging, I've actually supported nudging and choice architecture in the areas where they're for public health or public good. And I agree with the guidelines you sort of set for how do we decide in what context. I think those sort of ethical principles you articulated are really sort of valuable. The thing I worry about is in the context of business, and this is outside your talk, but I'm sort of wondering if you have any thoughts on it. The motive is not always to use these biases and heuristics for the purpose of the agent's own good. It's usually for the purpose of profit.
Yeah.
And so in that case, nudge, I think it by definition, it wouldn't be a nudge, at least how I understand nudges, because those are usually done, at least defined as Thaler and Susteen, are usually, what the agent would consent to, what they want, works within their own ends, is for the benefit of the agent, would consent to it and all these other kind of credit. In these cases, I worry, we can't really override and we can't really debug the biases enough to guard consumers. And how do we prevent bad agents from harnessing it in the context of profit, right? And so those are the areas where I'm sort of thinking about nudging, and I'm at a conflict because in general, public policy wise, and in healthcare, I see the value. But then I also worry about what tools we could implement. And I think, I mean, the more I talk out loud about it, my solution generally seems to be put policy protection in place.
That's right. I was just thinking law.
Yeah.
Laws, right? Like,
yeah, I mean, law seems to be sort of the big takeaway, I think. But it is hard and it's hard to legislate a lot of these. Like, so one of the things, like I always had this thought about writing a paper called "You Have to Put the Cake Somewhere." And so like behavioral science will tell us where we put the cake in the cafeteria is going to prioritize certain health choices, right? And I agree with you. There's no neutral choice here, right? Like once the behavioral science is out of the bag and we know put the cake at the beginning of the cafeteria line, children are going to choose it. If we put it in another location, they still have liberty, but it may it may de-incentivize them and they may make healthier choices. I always ask people who don't like nudging, what would you do? Right? Once we know the information, there is no neutral there is no default. There is no natural default. Like we could flip a coin, but that seems unethical, right? Because the outcome might be the one that prioritizes poor health outcomes. To prioritize poor health, that would seem unethical. And without choosing the last option, which is prioritize the healthy outcomes, my question would be, what other defaults do we have at our disposal? So I think once we know about the heuristics and the biases, it's very easy I mean, it's very impossible to create choice architecture, both for profit and in the context of nudging people in good directions they would consent to. And I don't know if we have enough policy solutions to or legislate enough to protect people from those kinds of I would say manipulative uses of heuristics. I take it.
Well, and I just think it's like hard to imagine even what the policy interventions would be, like the regulations, right? Like what would it even
I
look
could see
like?
it in tech. In tech, it's, you know, like there was lots of like dark patterns, the use of certain
Mhm,
kinds of technological heuristics that get
mhm.
consumers to purchase things they don't want. We could put things in place, but then there are other contexts where just positioning effects.
Right, like what are you gonna do? Like how are you gonna like we've been saying, because you have to position in one way or the other. So how are you gonna
Yeah.
like outlaw, business people or marketers from you? And I mean, to be fair, like uh, this has been happening, like marketers have been using these techniques for a long time, right? Like they aren't new. But yeah, no, I agree with you. I think that nudging in the context of medicine is a little bit easier because the ethical obligations are clear, right? The
Yeah.
physician's ethical obligations are clear that they're for the patient in front of them. And they're good, right? Like you have an obligation of protecting their, interests and their health. I think you're right that it is a much kind of more complicated and muddier picture in business and business ethics and what are the ethical obligations of people in business, if any. And you would think also that they have ethical obligations as humans, right? About not kind of problematically manipulating other humans, but how to kind of enforce that and monitor it. I think yeah, it'll be a really interesting discussion with your class, I'm sure.
Yeah. If I could just throw in one last
Yeah.
question, and then I'll see if anyone has a final thought. When you were talking about the two big ethical concerns, informed consent, autonomy, and then the other would be concerns that these biases may lead to the harm of the patient.
Yeah.
I was wondering if you had any thoughts on the potential future use of AI in healthcare and
Mm,
how these may be used to override a lot of the biases we discussed. Like,
mm,
and I see both negative and positive potential there, right? Like I have some real worries about outsourcing say medical decisions to AI, but we
mm,
also know physicians are human and physicians, just like patients, are going to be prone to a lot of these biases. Um, like just the ones you gave about statistics
mm,
and
mhm.
fractions. I mean, those are just, I have a friend who's a genetic counselor, and all she does all day long is give people probabilities, and people can't comprehend probabilities. They have such a hard time,
Um,
you know? Um, and so tools
mm,
that can help us calculate the risk factors might be to kind of use AI
mhm.
to sort of guard against some of these human biases. But are you optimistic or pessimistic about that use in the context of healthcare?
Yeah, it's a good question. Well, I'll say this. I've been doing some work on in the LVAD context again, using like algorithms or potentially AI to generate risk estimates for patients that, are more objective than maybe the estimates that the clinicians would come up with for any one individual patient. So I'm optimistic in the sense that I think like the algorithms and even the like AI, especially AI driven ones, can come up with probably better and more accurate and less biased estimates than the clinicians. But the clinicians have to believe that in order to use them. And some of our work, our early work, has been finding that clinicians and, in fact, patients still think that like the physician is going to be better than the AI. There's a kind of like overconfidence bias, I think, in the human. So I think it's going to be an interesting interplay that even if the AI is better at like various, overcoming various of these biases, which we'll have to see which one, is it just the statistical ones or is it also some of the deeper psychological ones? There's still going to be this human bias of like overconfidence or whatever all of our weird biases are that might not let us use AI and take advantage of its full capabilities.
Yeah, yeah, great answer. Any last questions? Let me see. I'll give someone one more minute. If Not, I'll thank the speaker. Thank you, Jennifer. That was a really wonderful talk. If anyone has any follow-up questions, feel free to contact Jennifer, or if you could contact me, I could pass you along. And I think if I'm accurate about our schedule, the next seminar will be by Luciano Floridi at Yale, talking about topics in AI ethics. So keep an eye out on that, and I'll put out the date and the Zoom link shortly.
Thanks so
you,
much,
everyone.
Greg, and everybody. Thanks for being here.